Testing 1 2 1 2. Test 1 2 3 1 2 3. Testing 1 2 3. Testing 1 2 3 1 2 3. Testing 1 2 3.
And does the audience have the opportunity to ask questions?
Whenever you get ready, we'll start. You are live.
Good afternoon, everyone. I'm David Geltmacher. I'm a professor of neurology at UAB, and I've been asked to speak today to give an update on Alzheimer's disease and where we are in the year 2020, a little bit of how we've gotten here and where we might be going. I'm also going to try to build in some practical tips for approaching the person with memory complaints that may or may not have Alzheimer's disease. In terms of disclosures, I'm an active researcher studying medications for treatment of Alzheimer's and related disorders. That funding is all paid directly to the institution, which then supports those research and pays my salary. I am a consultant on issues related to Alzheimer's disease to Genentech, to Grifols, and to the NFL Concussion Settlement Program. I will be mentioning medications and mentioning behavioral syndromes in Alzheimer's disease. Any medicine being used for behavior specifically in Alzheimer's disease is in fact off-label because there are no medications approved to treat the non-cognitive behavioral symptoms in dementia. All right, so Alzheimer's disease, what's the big deal? Why should why should you worry about Alzheimer's disease? Well, right now in the United States, there are about 5.8 to 6 million people who have dementia. Most of those, the dementia is due to Alzheimer's disease. That's the disease that's causing the clinical state of dementia. And about 500,000 new cases are expected this year, and that number continues to increase. The number of new cases continues to increase through the middle of the century. There are 7,000 new cases or more projected in Alabama alone this year. Just to put it in perspective, at its peak in 1993, the annual nationwide incidence of new cases of AIDS was 20,000. So we have a third of that right here in Alabama and 25 times that nationwide. So this is a very substantial public health crisis. And we have another problem, and any of you who have ever tried to refer to a neurologist or to me in our memory disorders program at UAB will know that we have a supply problem with specialists. To put that in context, there are more players under contract to the NBA than there are board-certified behavioral neurologists in the country. There are about 450 NBA players and just over 400 of us. There are 55 accredited fellowship slots in behavioral neurology, which means we could produce a maximum of 55 new cases a year, or new physicians a year in this area, but only 28 of those training slots were filled in 2020. Practice in Alzheimer's disease has not been something that allows one to make a living outside of the academic world, and so almost all of us with this certification and specialty in cognitive and behavioral neurology practice in academic settings. The projected any specialist capacity, that is geriatricians, neurologists, and geriatric psychiatrists who specialize in Alzheimer's disease, is going to increase only by 7% over the course of the next 20 years, while Alzheimer's disease will double in numbers. So we're not going to grow enough docs to manage this. So we have to think about different ways of approaching this illness besides just the specialists. One of the daunting aspects of the future is new medications. And so we anticipated in 2020 that at least one company would bring forward a new disease-modifying medication for slowing down the progress of Alzheimer's disease. That's been delayed by the COVID emergency, but if that medicine had come to fore and been available for marketing in 2020, the best modeling suggests that the wait time for any specialist, that is, again, any neurologist, geriatric psychiatrist, or geriatrician, would increase to over 18 months while waiting to be seen to do the specialized testing required to use this kind of immune-mediated antibody treatment. And the expectation from this projection out of the RAND Corporation is that over 2 million people would develop Alzheimer's disease while on the waiting list to be evaluated for it. So those are pretty substantial numbers. And so we need to think about different ways of addressing diagnosis and management of this population, then leaving it as a specialist issue. So one of the traditional views is that amyloid plaques in the brain are the cause of Alzheimer's disease. They damage the brain cells and accumulate. And most of us saw in medical school or in some pathology training some picture like this of the senile plaque. That's the dark area in the middle here of this photomicrograph. It's an accumulation of peptide, the amyloid peptide. And around it are the tangles, these flame-shaped tangles that characterize the pathology of Alzheimer's disease. This is what Dr. Alzheimer himself reported in 1906 and remains the basis of pathological diagnosis of the illness. But in terms of causation, we have actually moved beyond understanding the plaque as the cause into understanding that amyloid damage begins at the synapse before the plaque forms. And so amyloid peptide is a normal physiologic peptide. We all have it, we all make it. It shares some properties with some of the cell signaling peptide families in the brain. It has a strong tendency to accumulate into beta-pleated sheets, and before that, fibrils. And there is growing evidence that these fibrils, oligomers of the amyloid peptide, are toxic at the level of the synapse, and that the plaque is actually a means of sequestering these toxic substances away from the damaged tissue. So the plaque, rather than causing Alzheimer's disease, is a consequence of the amyloid overproduction or underclearance, but not the cause of the disease itself. So it's the pathological hallmark, but not the biological cause. One of the things that's helped us understand this is the emergence of biomarkers, in particular CSF biomarkers for the amyloid peptide that makes up the plaque, and of the neurofibrillary tangle, which is composed of the peptide tau. And using PET scans in particular, Cliff Jack and colleagues at the Mayo Clinic have identified that amyloid begins to build up in the brain, measured by PET scan, while someone's still clinically normal. And that can continue on, causing secondary damage like the synaptic dysfunction that I talked about. That's represented by this orange curve. And then generating the tangles, or the tau pathology. And by the time someone gets to noticeable cognitive impairments, even mild cognitive impairment, amyloid and synaptic dysfunction have reached very high levels. And it isn't until much, much later that memory loss begins to become noticeable, and eventually the functional loss that characterizes dementia. So we need to reformulate our whole approach to Alzheimer's. We can't wait in the future model for people to have lost the function that characterizes dementia. We need to identify this as a biomarker disease and intervene on that biomarker before the damage has occurred. That's not unlike what we've done with heart disease, where in 1965 we understood someone to have heart disease when they had a heart attack. And now we understand them to be in the process of heart disease, which can be marked by an elevated A1C and elevated cholesterol years or decades before the first symptoms, and we intervene at that point. And that's the hope for Alzheimer's intervention in the future. Another thing is that when we study these peptide abnormalities in Alzheimer's disease, that the amyloid and the tau, although both appearing in the pathology, occur in different regions, or they're concentrated in different regions. The amyloid is a very widespread accumulation throughout the brain. And the tau pathology, the tangles, follow a much more restricted and, as I pointed out in the earlier slide, delayed onset. So the possibility of identifying someone with accumulating amyloid before there is significant accumulation of tau may help preserve neuronal function. This distribution of tau, the tangles also helps us understand why Alzheimer's disease looks the way it does. So these cuts here are on the mesial surface of the brain, but if we move out to the lateral surface of the brain and think about some of the behavioral phenomena that localize on the lateral surface, this is the left hemisphere, we have memory in the inferior temporal lobe and verbal memory in particular throughout the temporal lobe. Language has a focal point in the classical Wernicke's area at the junction of the temporal lobe and parietal lobe. And spatial processing is a parietal function, especially in the right hemisphere. And this, based on the accumulation of tangles as seen in pathology cases, this is where most of the damage is in the brain, and the symptoms of Alzheimer's disease are problems with verbal memory and problems with spatial orientation and navigation. The other area is the inferior frontal lobe, and that does loop around into the mesial frontal lobe, and so behavioral regulation becomes an issue in people with Alzheimer's disease. So we may see apathy or eventually disinhibition, agitation, and psychosis. But like all of neurology, the pathology of Alzheimer's disease predicts the clinical pattern of the illness. It's not just memory loss, there's much more. And it's actually those other things that help us in differentiating the Alzheimer's from other forms of memory loss. So if specialists can't do this all, then obviously folks on the front lines, our primary care providers, physicians and nurse practitioners will need to have some understanding of what Alzheimer's disease looks like and who needs to get passed on to those specialists, or who can be treated earlier or treated for other things to potentially avoid, one, the diagnosis of Alzheimer's, and two, that long delay for appropriate diagnosis and therapeutics. So the core questions in approaching dementia is the problem neurological? Do we need a neurologist or not? And then within that is the problem with the structure of the brain, degeneration, atrophy, stroke, or is it in the function of the brain? Things like epilepsy or encephalopathy from other causes. Another very important question is the problem reversible? We don't anticipate in the foreseeable future treatments that will restore neurons to health. So what we need to do is identify if there are other reversible factors and take care of those and try and prevent more neurons from dying. And so that dovetails in with that second question, is the problem degenerative? So if it's not a degenerative dementia, we need to focus on things like preventing stroke and the vascular components of dementia and so forth. Excuse me. So I've talked about dementia. I've thrown the term around a little bit. Let's be sure we're all on the same page when we talk about dementia. The current definitions of dementia evolve out of a 2011 consensus between the Alzheimer's Association and the National Institute on Aging for research diagnosis, and these have migrated now into clinical practice and are reflected in things like the DSM-5 and in the ICD-10 nomenclatures. But dementia is characterized by cognitive losses that interfere with a person's usual activities. So just complaining of memory loss does not make it dementia. You actually have to lose the ability to do things that you had previously done. So it's a decline in function. It's not acute like a delirium. It's not a primary psychiatric disorder. Those can cause plenty of dysfunction, but they don't fit into the category of dementia and need to be treated in a different pattern. Their time course is also different. Dementia is not diagnosed by a test. It's diagnosed by history and examination. There's no cutoff on a test like the Mini-Mental or the Montreal Cognitive or the SLUMS that says you are demented or no, you are not. So a person, one of our colleagues up in Huntsville, an astrophysicist with a PhD and spent 30 years studying the movement of galaxies, he may still score a 30 of 30 on the Mini-Mental and be significantly impaired in his cognition so that he can't do his work. On the other hand, there might be a pipe fitter in the same building where he works who didn't complete the 8th grade. And his score of 20 or 22 on the Mini-Mental may be completely normal for him. And so we can't use a single cutoff to say who has dementia and who does not. Also, to be sure that we're not dealing with the effects of a single focal lesion, like a single stroke, defining dementia requires two cognitive domains to be impaired. So memory is the most common, it's not obligate, so memory and something else. And using the DSM-5 categorizations, things like reasoning and judgment, visuospatial and language impairments are all potentials that could help contribute to the overall dementia state. What's clear to us is that a patient walking into the office is saying, "Doc, I have short-term memory loss." That does not equate automatically to Alzheimer's disease. In fact, the words short-term memory loss don't mean anything. They mean what that person means by short-term memory loss. Psychologists have a very strict definition of what short-term memory loss might be, but in common usage it is, I forgot something. It may be I forgot something that happened very recently. It may be that I forgot something for a short time. So there are things that get lumped together into the patient complaint, and many times the provider's understanding of short-term memory loss might include distractibility. Where did I put my keys? Slowed recall. I can't remember the name of the 17th president of the United States right now when my grandson asked me, but a few minutes later it comes to me. Word finding. I think all of us have had the experience of wanting to express a thought, and the word to do it isn't there right at that moment. We come up with some poor substitute. We walk out of the room or out of the meeting, and the word pops into our head. Names are particularly difficult, and slowed recall of names is a very common complaint, but it is part of the aging process for most people. And then route finding problems. Again, many of us have had that experience of coming up to a stop sign on a route that isn't necessarily one we drive frequently and thinking, do I turn left here or do I turn right? So for some people, that's short-term memory loss. And for other people, it is not remembering the route that they last took 6 months ago. So certainly not all of these need a memory clinic, and most of them don't even need a neurologist, at least for the first pass of approach. The Academy of Neurology has attempted to put together practice parameters for many common problems. The practice parameter for dementia has become somewhat of a struggle within the Academy as to what evidence should be included. So our current practice parameter is nearly 20 years old, and as I said, it's caught up in some very meaningful debates as to what should be included in the revision, but that has prevented the revision from coming through. But the Academy's recommendation is to screen for depression, to conduct cerebral imaging, and routine laboratories, including blood counts, routine chemistries, vitamin B12, and thyroid. Now, it is important to recognize that these kinds of lab abnormalities account for fewer than 10% of dementia cases overall. And if we got to a memory clinic kind of setting, they account for less than half of 1%. So we do the blood tests frequently, but they're not often the cause of the dementia. More often they're a contributing factor. One thing that's emerged in blood tests since the Academy's recommendations in 2001 is that low vitamin D levels are associated with more rapid progression of many neurologic syndromes. And so vitamin D testing has become the norm, and repletion of vitamin D when it's low has also become typical in folks with memory complaints. So we're going to talk in some detail about Alzheimer's disease and some of the other structurally mediated causes of dementia. But in the primary care setting, in the emergency room setting with cognitive impairment comes up, there are certainly other things that need to come to the top of the list for consideration. And things that cause reversible cognitive impairment beyond low thyroid or low B12 include regular old prescription drugs, alcohol, other drugs like medical marijuana. Pain is a common contributor to impaired memory, and of course the medicines we use to treat pain can also impair cognition. And then the increasing prevalence, or at least the increasing recognition of sleep apnea and other sleep disorders are important contributors to cognition, or sleep is an important contributor to good cognition. Impaired sleep frequently impairs cognition. So those are things for us to consider and get in our histories as we approach the person who is concerned about their memory function. Let's go into a little bit more detail on these non-structural causes of memory complaints. Most of them are built around the construct of working memory. Working memory is basically how many balls can you keep in the air at once? And in the classic psychology experiments of the early 20th century that looked at what is working memory, how do we form it, what do we do with it, and so forth. Their experiments suggested that most of us have a working memory with about 7 slots in it. We can keep 7 thoughts in our head, or 7 things can be readily accessed at any one time. There's folklore, I don't know if it's true or not, but that's why phone numbers before area codes had 7 digits, as that was the maximum that a person could remember for a short period of time. Anything that occupies consciousness is occupying parts of working memory. So that if you hurt and it's drawing your attention to that, if you're fatigued and you're consciously working to offset that fatigue, if you're anxious or depressed, those are all things that occupy those slots in your working memory. And when that happens, it interrupts the ability to put more information into working memory, that is to call things out of our existing memories, or to put things into memory from the exterior environment. So essentially those stimuli that interrupt rehearsal or to occupy slots in the working memory can reduce both recall and formation of new memories. And our non-structural causes of memory loss are focused on disruptions in the working memory. We can also think about the classic curve between arousal and performance. This was described right around the time that Alzheimer first described Alzheimer's disease. And most people who've taken a couple psychology classes will recognize this. But it's the link between a pressure or arousal and the ability to do a task. And when someone has low arousal, they're going to have low performance. The classic example of that is sleep. Sleep is a very low arousal state, and many of us don't do much. We're not paying our bills. We're not solving arithmetic equations when we're asleep. And when we first wake up, we may not be very good either. And that's because that arousal hasn't yet risen to optimal levels. On the other hand, being overstimulated can also lead to impaired performance. And this is the person who is hyperkinetic and distractible. This is what leads to cognitive impairment, say, in mania, or when people take overdoses of stimulating drugs, or they use illicit stimulating drugs like cocaine. In the middle, there's a sweet spot. There's a sweet spot where our arousal and our performance are both optimized. And you can go over the top a little bit too much. I remember experience in college where I was studying for a physics test, and I had a lot more equations to memorize for that test tomorrow morning, and it was getting late, and I thought a cup of coffee might help, and it did. And then I had a second cup of coffee thinking it might help more, and it didn't. I was now fidgety and distractible and couldn't get those equations memorized the way I wanted to before. So thinking about people who are overstimulated and the impact that has on memory, and people who are understimulated and the impact it has on memory. So if we think about understimulation, a really common one is depression. And depression is present in up to half of memory clinic referrals nationwide. It's important when dealing with depression that the person may not complain of sadness. So there's a common perception that depression, in the public, that depression is the same as being sad. And being sad is one of the 2 possible criteria, but loss of motivation is another criterion that can identify depression. And men especially do not express much sadness. They may have apathy, agitation, irritability. Those are very common in men with depression. Typical symptoms are I can't remember anything, or I'm slow at remembering things, and critically it's of both new and old information. When someone says I can't remember things from my childhood, that's not Alzheimer's disease unless they've forgotten a lot of other things between now and their childhood. Distractibility, as I mentioned, misplacing items, leaving tasks unfinished. This is the person that forgets that a burner is on or forgets that there's wash in the washing machine. What's interesting is even as the mood resolves, cognition will improve, but may not return to complete normality. People will often have, as a part of the depression syndrome, even when mood has returned to normal, subjective feelings of reduced capacity, reduced willingness to undertake things that might trigger failure. So that ends up with some learned helplessness or the typical pattern of giving up on a more difficult cognitive task. So if you ask a person to do a task and they answer, "I can't," rather than trying to struggle through it, I worry about mood issues as a contributing factor. I got an illustration of that, actually. So under the label Mrs. D is an attempt to copy the Pentagons from the mini-mental exam. Her overall score in the mini-mental was 23 out of 30, but when we got to the Pentagons, she'd already missed several items, and so she was a little bit anxious and a little frustrated by that. And when she drew the first Pentagon perfectly normally, then she became a little confused and distracted. She tried to draw the appropriate line for intersecting the Pentagon and said, no, that's not it, and started to cross it out, and just became completely flustered and said, "I can't do this." On the other hand, a more typical pattern, say in Alzheimer's disease, is a surprise that the failure is occurring and a continued effort of trying to solve the problem because they don't understand why they are not getting it done. So this I just pulled off the web, but these are the Pentagon model figure, and this person with Alzheimer's disease mimics one and draws another, and it doesn't really project all that well, but there are multiple hashes over these lines where the person kept trying to make it right. They couldn't get the fifth leg on the second Pentagon, but they continued to work at it and work at it and work at it. Anxiety and depression often travel together, and in fact, a depressed person making cognitive errors often provokes anxiety. So we see similar effects on cognition. If depression is at the low end of that arousal and performance curve, anxiety is at the high end. So the person who's fidgety and restless and anxious may not remember things. They're going to have problems with making new memories and learning. They're going to have problems in information processing because they keep getting distracted away from the thought process. And so they will complain of problem-solving difficulties. They'll complain of poor memory. It is important to note that persistently untreated anxiety can put significant stresses on the neuronal structures that underlie memory, the hippocampus in particular. And in animal models, unrelieved stress, which we would model as anxiety in humans, accelerates hippocampal atrophy and reduces memory performance. Chronic pain is a really big one. I see a lot of folks in our memory clinic who are convinced they have Alzheimer's or some other form of dementia, complaining of pain scores of 7 out of 9, taking hydrocodone or oxycodone, taking gabapentin at 1,200 milligrams a day, and then they wonder why they're not thinking as sharp as they used to. So acute pain is a really good thing for us to have, and it evolved for reasons. And when you touch a hot stove or step on a pointy stick, that acute pain tells you, hey, pay attention to me, there's something wrong going on here, fix it right now. So pain is outstandingly good at getting our attention. Unfortunately, chronic pain is drawing attention to things that are always there and maybe drawing our attention away from things that deserve it. So we see deficits in attention in people with chronic pain. Because they're being pulled away from the task at hand, mentally and internally pulled away, their processing speed slows down. They don't have as many resources being devoted to the problem solving. And whenever attention is down, and whenever the speed of processing and recall is down, people will complain of poor memory. Some other things magnify these impairments. So things that are very common in people with chronic pain syndromes: somatic preoccupation. They spend a lot of time paying attention to their body's function, including their memory. Pain frequently interrupts sleep and is associated then either as chicken or egg or both with fatigue during the daytime. And it's important that emotional distress predicts cognitive complaints much better than the reported severity of the pain. So if we ask someone to rate their pain on a scale of 1 to 10 and ask someone to rate their distress in response to that pain on a scale of 1 to 10, the distress is the better predictor. So one way of thinking about that is suffering with pain is a better predictor of its impairing effects on cognition than just experiencing pain. I learned this from my own mother. She would walk around. She eventually had both hips replaced, but she'd walk around the house, making little sounds of pain. Oh, ah, ooh. And I said, "Mother, is that hurting?" She said, "No." It wasn't attributing any distress to the pain that she was clearly experiencing and non-verbally expressing. Sleep. When people complain of poor sleep, I think all of us know that complaining of poor sleep and experiencing poor sleep are actually different things. I have plenty of people who tell me, "I haven't slept in a month." It's not physiologically possible, but what they are saying, I think, is they haven't been happy with their sleep for a month. And when people report poor sleep, we often will find difficulty with memory. They'll have low mental energy, low motivation. They'll have problems with concentration and decision making. And if we look at it in the laboratory setting, cognitive performance is reduced with sleep deprivation. That's why we have work rules for residents now, is to reduce the the risk of adverse events from impaired cognition from sleep deprivation. And so when we induce sleep deprivation, we see problems in attention, working memory, long-term memory, and decision making. Some people seem much more resistant to this than others. The inter-individual differences that predict who's going to have bigger effects on, who's going to have bigger cognitive effects from sleep deprivation, who's going to have less, is not clear. One thing that is apparent is age. So the older we get, in general, the less well we deal with subjective sleep disturbances. And of course, there are medical conditions that require treatment. Depression, anxiety, pain, those are things we want to treat to relieve suffering and improve function. But when treating pain with opiates, for instance, we get sedation and cognitive impairments. Those impairments can last 4, 5, or 6 hours after even a single dose of oxycodone. The treatments that we use to reduce neuralgic pain, things like gabapentin and pregabalin, they have sedative effects. Those are relatively idiosyncratic, but the people who have more sedative effects seem to get more cognitive problems. It's not dosing alone, but for a person who is sensitive to the sedating effects of those medications, there is a dose-response relationship where higher doses will lead to greater impairments in cognition. Treating anxiety or sleep disturbance with benzodiazepines, very effective at treating those primary targets, but we can anticipate problems in attention, working memory, planning, and mental flexibility on people who chronically use benzodiazepines. And this can extend even to the benzodiazepine-like agents that are used for sleep. I think any of us who've ever worked with Versed or personally experienced Versed know how potent an amnestic effect an acute benzodiazepine can have on an acute acting benzodiazepine can have on someone's cognitive abilities. And then anticholinergics. These are extremely commonly taken. People take them for cough and cold, they take them for perceived allergies, and they take them for sleep. And so any of the agents that indicate a pain reliever's name and then end in PM is diphenhydramine, and that is one of the most centrally active of the antihistaminic anticholinergic agents and can lead to significant problems with cognition and increase the risk for developing dementia. So let's start to talk about the dementia syndromes that are more structurally mediated. And the front door to dementia is what we call mild cognitive impairment. So if dementia, and I showed this definition earlier, is a change in cognition that's sufficiently severe to interfere with daily function, mild cognitive impairment is a change in cognition that's sufficiently severe to be detected by the affected person or by cognitive testing or by those around them, but who is able to maintain their daily function. Sometimes mild cognitive impairment persists, but for the most part, MCI, as we'll abbreviate it, is a transient state. People either get better or worse. Very few stay chronically and persistently at the same level of impairment. So the clinical criteria for MCI, I've summarized these, but I wanted you to be able to see them as well. A concern for a change in cognition reported by the patient or an informant who's knowledgeable, or the clinician. So if we've been following someone in the office for years and they're showing signs of not being as sharp, or they're messing up their med refills in a way they never have before, when we start to think about that as a concern, and that could be mild cognitive impairment. There also needs to be objective impairment. So when asked to remember words on a memory test or generate words out of long-term memory, that there should be some level of objective impairment. This can be subtle to detect in a typical practice situation in family medicine or internal medicine. It may require more detailed neuropsychological testing. But when there is worries about memory, but no objective impairment on any domain of cognition, that's a less concerning state called subjective cognitive decline. So the objective changes in MCI are important. As I mentioned, the defining factor between MCI and dementia is the preservation of daily function in MCI. So people can have mild problems in performing complex tasks like bill paying or meal preparation. They may take more time or be less efficient, but in the end they are able to do things. So that makes them not demented, and that's what makes MCI MCI. I'm often asked by colleagues outside the practice of neurology, someone's complaining of memory loss. When do I really need to worry about that? When is that something I need to start to intervene upon or engage them with? And the bright line for that is clearly loss of function. And the less bright line is when people say it's a struggle for them to achieve past functions. And we'll go into a little bit more about the important role of function. So let's talk about the irreversible dementia syndromes now. And I think of these, you can break this down in many ways as you want, but there are the big four that are going to account for a large majority of all later life structurally mediated dementias. Alzheimer's, frontotemporal, DLB, that's dementia with Lewy bodies, that's the dementia expression of Parkinson's, and then vascular dementia, the dementia expression of stroke. Vascular dementia, of course, has been recognized for a long time, previously called multi-infarct dementia. What we understand from autopsy studies these days, and largely as a result of the success of our antihypertensive therapies over the last half century, is that vascular dementia is very rarely the primary cause of dementia. It's more likely to be an exacerbating factor. So let's talk about Alzheimer's. I've already shown this slide where the pathology predicts the symptoms, where the tangles accumulate in the brain of the person with Alzheimer's, predicts the symptoms. And so one way of thinking about Alzheimer's disease is the straight A's of Alzheimer's disease. It's an amnesia for recent events and activities. What happens in Alzheimer's disease is people have a hard time learning new information, phrased another way, a hard time making new memories. So it's not just forgetting conversations or birthdays or appointments. It is a guest speaker came to church, a grandchild graduated, and we had a family party, and the person does not recall the experience. That's the red flag for the type of amnesia in Alzheimer's disease. Not remembering a conversation about what to pick up at the store, or going to the store and not remembering the 19th out of 20 items. Those are not Alzheimer's type complaints. There needs to be more than just that. Beyond that, because of the location of the damage in the brain and the fact that it's been accumulating for maybe a decade or more before the first symptoms, there should be more than just memory detectable on examination or history. That's where things like anomia, a consistent pattern of not coming up with words, apraxia, not being able to manage tools. The really common one is a person gets a new phone and can't manage learning a new phone, or they get a new TV and the remote is different than the old remote and they can't figure out how to work it. Agnosia, not recognizing familiar locations or routes, not recognizing familiar people. Those are things that also fit with the location of Alzheimer pathology. These need to be severe enough to interfere with the person's usual function, so reduced function in their roles in home and work. And one thing is that these folks often don't complain themselves about the problem. two factors will mask the straight A's of Alzheimer's disease, and they're also A's. Anosognosia, that is the organic unawareness of illness. People with AD literally forget that they forget what they forget, and when challenged with being forgetful, they can enlist an entire lifetime's worth of memories of all the things that they do remember. And so this can be a particularly significant thing. So the person living alone very rarely presents with Alzheimer-type symptoms because they don't see it as a problem. Apathy, they may see it as a problem but not be motivated to seek care. They may say, well, this is normal for me in my age. Or they have a family member who's pushing them, you know, Daddy, please call the doctor. Please get in there to see him about your memory. And the patient simply never picks up the phone. We use, I've carefully used the word structurally mediated, and we use structural imaging to understand how Alzheimer's disease presents in the brain. If any of you have ever had folks come see us at the memory clinic at UAB, you'll hear us or read in our reports talking about the grading of the hippocampal atrophy. So it's a scale that runs from 0 to 4, where 0 is no atrophy and 4 is very significant atrophy in the hippocampus, and ERC is entorhinal cortex. If you're in your 60s, or certainly if you're in your 70s, the middle range of a hippocampal atrophy score of 2 is not particularly concerning. That warrants follow-up and determination of whether it's getting worse. But if you have hippocampal atrophy scores of 3 or 4, you are either have or you're on your way to an Alzheimer-type dementia in almost all cases. There's subtleties to that. Our radiologists at UAB have some additional practice and training in reading these scans. A lot of our radiology colleagues in the community don't use these grading scales. But our memory group at UAB, we read our own scans, and we also have our radiology team that supports that. The future is probably going to move toward functional imaging or molecular imaging for diagnosis of Alzheimer's disease. And what we may see in more and more routine use within the next 10 years are PET scans detecting the amyloid beta, or now the tau, the tangle. So the FDA just approved the first tau imaging agent. None of the payers pay for these yet. Medicare and Blue Cross and others don't pay for these scans, but they are FDA approved, meaning the sponsors have demonstrated that the agent does what they said it would do. And so we can detect large accumulations of Alzheimer plaque in the brain. One of the things that we struggle with is, what does that mean? So if Alzheimer's pathology is building in the brain already for a decade before the first symptoms, what does it mean when someone has normal scores and an accumulation of amyloid? Are they on their way to dementia, or is this a chronic state? And since the tau pathology, the tangles, relate more closely to symptoms, we don't have a good answer to this question yet. What we do know is that about 30% of cognitively well people in their 70s and above will have detectable amyloid accumulations in their brain. And that's when they've also been demonstrated to not have neuropsychological test performance abnormalities. So we have more work to do on this. So we do, at this point, principally focus on the clinical history and then that pattern of structural imaging with hippocampal atrophy. Now, Alzheimer's, either by itself or with another pathology like stroke, is going to account for 75, 80 or more % of all late life dementia after age 75. There are some non-Alzheimer's syndromes, and these tend to have a somewhat earlier expression. Most common of these is the frontotemporal dementia, and there are two big families of the frontotemporal dementia. One is the behavioral variant that many of us learned in school as Pick's disease, and these are people who have changes in behavioral regulation, and this relates largely to frontal lobe function, in particular right frontal lobe, to some extent the right temporal lobe as well. There are also two language presentations, and not surprisingly, these have left hemisphere focality. The non-fluent or agrammatic type of progressive aphasia sounds a lot like the classic Broca's aphasia that many of us saw in school or see in our patients with frontal strokes. And then semantic dementia is a loss of word knowledge. This is very striking. It's rare, but very striking. I had a lady that I saw one time who I thought was crazy when she told me her complaint was, I don't know what words mean anymore. My friends told us to meet up at Burger King and I didn't know what Burger King meant. It sounds like a kind of complaint that a neurologist doesn't often put a lot of stock into, but in further exploration she really did not know what thoughts were associated with specific words. There was a disconnect between them. In the frontotemporal dementias, a long, subtle prodrome is very common. It's typically mistaken for midlife crisis when we have disinhibited behaviors, particularly sexual disinhibitions or gambling. And then in people who are more apathetic as their presentation, it's commonly mistaken as depression, but very resistant to antidepressants because the neurochemistry is different. And this represents loss of brain cells in the mood regulating centers of the brain. All right, vascular dementia. This is perhaps, at least up until maybe the last 10 years, the most overdiagnosed of the dementias because we could see stroke and stroke-related changes on CAT scans and MRI scans. And so the assumption was, well, if I can see the strokes, they must be the cause. And that may be true, at least to a certain extent, with CT. We know MRI is very, very sensitive to white matter changes, and not all of those have strong clinical correlates, at least at the level of dementia. So for vascular dementia, the things I look for are people with slowing. If you have enough vascular burden to interfere with cognition, it's usually going to be enough vascular burden to slow you down mentally and physically. So we'll see gait problems and maybe some urinary control issues. Apathy and depression is very common with this as well. But what we don't have is the typical problems with making new memories. The problem is more in a dysexecutive state, that is knowing what to do and when to do it, and a slowing of recall of existing information. Many, many people, the majority of people in my opinion with vascular dementia, retain insight into their symptoms. So I talked about the person with Alzheimer's forgetting that they forget. The person with stroke-based dementia often is acutely aware of their forgetfulness and angry and frustrated about it, looking to ways to solve it rather than denying its presence. So we have scans that push us toward the diagnosis of vascular dementia, but there are things that we need to look at in the clinical history that should push us away from vascular dementia. So if there are no other neurologic signs other than cognitive decline, vascular dementia becomes less likely. If there are no vasculopathic risk factors, that should make it considered less likely. Those vasculopathic risk factors, the diabetes, the hypertension, the hyperlipidemia are all independent risk factors for Alzheimer's as well as stroke. If we have aphasic disturbances, people with disorders of language expression or comprehension without corresponding left hemisphere lesions on imaging, we should push away from vascular dementia. And then if there's only patchy or periventricular white matter disease on their CT or MRI scans, or that affects less than 25% of the white matter volume, the likelihood that those strokes are the cause, or that ischemic disease is the cause of the dementia by itself, is very, very low. So the presence of risk factors alone is insufficient to diagnose vascular dementia. What we do know is those same stroke-like features, either by history or typically by imaging, will magnify the expression of other pathologies. So for a given amount of Alzheimer pathology in the brain, let's just make up a number, 1 plaque per high-power field, if the person has no vascular disease, no stroke-like damage in the brain, that degree of Alzheimer pathology is unlikely to lead to cognitive symptoms. But if they have that 1 plaque per high power field and they also have stroke-related changes elsewhere in the brain, they are much more likely to express cognitive decline. And that decline is likely to look like an Alzheimer pattern of decline with that same symptom pattern I showed before. All right. Dementia with Lewy bodies. Lewy bodies are pretty common in autopsy, so some people will say this is the second most common form of dementia. But in our practice, at least with our memory disorders clinic, we see more of the frontotemporal dementias than we see the Lewy bodies. That may be very different in a person with a Parkinson's-oriented practice. The real critical finding with dementia with Lewy bodies is these people have visual hallucinations early in their course of dementia. So people with Alzheimer's and other forms of dementia will often hallucinate later in the course when there are severe and pervasive cognitive impairments, but hallucinations in mild dementia fit very strongly with the DLB. They're often associated with parasomnias like restless legs or REM sleep behavior disturbance. They're often described by family members as acting out their dreams. The Parkinson's features tend to be quite mild. Tremor is infrequent. The masked face is not unusual at all, but it's typically a reduced blink rate rather than that reptilian stare or completely blank face that is sometimes described. When doing cognitive testing, these folks have more of an executive and visuospatial pattern of impairments rather than the dense amnestic pattern that characterizes Alzheimer's disease. So they may have problems with drawing the clock or copying the cube. They may have problems with serial sevens or adding pocket change, but remember more of the words from a word list. So let's talk about some practical approaches to assessment. And I'm specifically going to talk here about the non-neurologist. So is this a Medicare wellness visit? Is this a mental health visit for a counselor or a psychologist or a psychiatrist? So we want to think about that rather than what a specialist is going to do in this situation. So one of the most highly recommended tests for cognitive screening, for instance, in the use for the Medicare wellness assessment, is the mini-cog screening test. The mini-cog is very simple. We ask the person to repeat 3 words, draw a clock, and after completing the clock, recall the 3 words. And the scoring algorithm is pretty common, pretty easy to understand as well. So if a person recalls none of the 3 words, or they recall 1 or 2 of them, and their clock drawing test is abnormal, we want to worry about them. They need further evaluation. They may need to come back for more detailed testing by the practitioner identified these, maybe do a full mini-mental or a Montreal cognitive, especially if neurology resources are short in your community. On the other hand, if the person either recalls all 3 or recalls 1 or 2 and does well on the clock, it's likely not a dementia syndrome and probably can be observed and retested at an interval down the future. But it's, these test is obviously not definitive for the presence or absence of Alzheimer's, but it can point us to those people we need to worry more about or not. Let's go on some more about the relationship between function and cognition. These structural brain diseases, Alzheimer's, Parkinson's, stroke, and so forth, they usually show a strong correlation between performance on cognitive tests and performance in activities of daily living. So severe memory impairments are associated with severe problems in daily function. When we deal with the software issues, the non-structural ones like mood, pain, sleep, and so forth, we're more likely to see a mismatch. The person who says, "Doc, I can't remember anything anymore," yet is functioning at work and maintaining their day-to-day abilities. So there's kind of a flow chart that I think about for these folks. So the person with memory complaints who does well in cognitive performance, their conversational language is intact, they do well on the mini-cog, but they complain that they can't function at work. So they've got these objective and subjective impairments in cognition, but they're intact on those things, but they can't work. I think about non-structural causes. The flip side is also true. Doc, I can't remember anything anymore, scores very poorly on the mini-cog, but is maintaining themselves in the workplace, maintaining their family role. Those point toward those software issues in the middle. But low performance on screening, low daily function, we start to think about structural brain disease as a much more high likelihood event. Well, one other rule is who's telling the story. If the patient's telling the story about how badly impaired they are, I listen to that but think non-structural. But when the family members complain to me, I really start to think about those structural causes as being a more predominant factor. None of these are 100% cuts, but they are helpful in understanding which pathway we want to follow. So quick summary here, the non-structural causes of memory complaints, they tend to be reflective of inattention, distractibility, and memory lapses, that is a forget now but remember later on. These represent transient retrieval failures, and they're common correlates. Things that we see along with it is the person who gets very anxious at their lapse in memory, person who has low self-confidence on their memory and won't pursue a more difficult task or test, and the common associations with things like pain, fatigue, insomnia, and medications. In Alzheimer's disease, on the other hand, we have impaired memory formation. They don't make new memories, and those that they do make, they forget rapidly, and once that's forgotten, it's gone forever. So at the end of a church service, they may tell the pastor, I really loved that sermon today, can't hear the story of Cain and Abel enough. And then the next day, someone asked about the sermon, and they have no recollection of it. That's rapid forgetting. And once it's gone forever. And common correlates here are people who try to figure out why they've forgotten this way. They try to use a logical explanation of their forgetfulness. And it often doesn't hang together very well. And so they have a low awareness of their deficits, and they tend not to be particularly worried about either the memory deficit or other somatic issues. It's more of a blasé indifference, which is typical of those lapses when Alzheimer's disease is the cause of the memory problems. I want to wrap up with just a few minutes on therapeutics. When we first agreed to give this talk, it was almost a year ago when I said I'd be happy to. I thought we'd have a new drug on the market by today. COVID-19 and a number of other factors pushed us away from that. So we don't have a new drug on the market in 2020. We haven't added a new drug since 2014, really. What do we know about our existing medications for Alzheimer's? The cholinesterase inhibitors have now been in use since 1993, so we've got a really good long track record with them, 27 years. And what we know about them, regardless of which one, if they're used in mild and moderate Alzheimer's disease, that is specific to that clinical diagnosis of pathology and at the stages of mild or moderate, they will delay declines in cognition, and they delay them for about a year or so on average. And here are 3 different agents and 3 different double-blind placebo-controlled trials, all with very similar results. The other medication that is in common use is memantine. Memantine has been approved only for moderate and severe Alzheimer's disease. It's not been approved for other forms of dementia. And so when used in this labeled indication, we see that over the course of 6 months on a cognitive battery, the severe impairment battery, people treated with the memantine do better than those treated with placebo, even though they're worse than where they started. So this is an effect relative to placebo, not to baseline. Importantly, when these folks who had been on placebo previously were started on medication, they also showed a period of stabilization, but by the end of the year, that effect was gone. So what this suggests to me is the efficacy of memantine typically will fade somewhere between 6 and 12 months. It does not give us the same longer-term benefits that have been demonstrated with the cholinesterase inhibitors. More importantly than memory test scores or how long the effect lasts on memory test scores is the impact on family life. And this is from one of the early double-blind placebo-controlled trials of galantamine. It showed that over the course of 5 months on treatment, people taking placebo had an increasing demand on their caregiver time of about 20 minutes. And those taking the active drug, the galantamine, had a decrease in caregiver time of about 40 minutes, an hour's difference over the course of 5 months. So this is an hour that the caregiver could do more of what they wanted to do and less of what they needed to do in care. And I know myself that if you said, hey, do you want an hour back of your own time today where you didn't have to take care of someone else, I would probably take that. And this is one of the real values, but it's hard to measure this. And also this was in a double-blind placebo-controlled section, so neither the patient nor the caregiver knew what they were taking. And importantly, the rater who collected this information didn't know what the person was taking. So I count this as a valid result. It's been something similar seen for memantine as well. Behaviors. We know that cholinesterase inhibitors are not very good at responding to agitation or irritability. Those have been tested and not very positive with that. Really, citalopram is the only drug in double-blind placebo-controlled trials that's shown a good mix of safety and efficacy against restlessness and agitation. But in folks who got the cholinesterase inhibitors and then in a double-blinded fashion had them temporarily removed or suspended, behavioral symptoms and, more importantly, caregiver distress increased. So these drugs played a role, the cholinesterase inhibitor, it was in this case donepezil, played a role in reducing caregiver distress that re-emerged when the drug was stopped. So these are meaningful things to our caregivers, and when I talk about what to expect with the medications, I often talk about the benefit to the caregiver more than the patient, him or herself. So let me summarize in the last minute. The concepts of Alzheimer's disease have shifted over the years, and now we understand that the disease state, the pathology, is present and detectable before the first memory symptoms emerge. The plaques and tangles are markers of the disease, not the cause of the disease. We understand that non-structural causes of memory loss are frequent, especially frequent in primary care settings. And these are identified by mismatches between complaints and test performance or complaints and daily function. Working memory is the primary deficit in the software drivers of memory loss, and the arousal performance curve helps also to explain it. Low arousal, low performance, overstimulation, poor performance, etc. Our Alzheimer's therapies have meaningful benefits, but those benefits are not something that we can say they improve memory performance. They stabilize cognition, they delay worsening, but not improve the cognitive test scores over the course of 6 or 12 months. We do know that they are associated with reduced caregiver burden, and they are also associated, probably as a result of that reduced caregiver burden, with delays to need for nursing home or other types of institutional care. So that's where we are in the world of Alzheimer's disease 2020. I hope you found the information useful, and we'll be able to turn to it for reference in the future.